Fluoroscopy is emerging as a primary tool for interventional and surgical procedures in addition to still being viable in diagnostic radiology. Fluoroscopy as a diagnostic imaging modality has been impacted by the development and advancement of other imaging modalities in several ways. The use of fluoroscopy for diagnostic purposes has been declining for decades. This is believed to be due to the availability of other imaging procedure options for diagnosis, such as CT and MRI. While the use of fluoroscopy for diagnostic purposes has decreased, its use for image guidance during procedures has expanded dramatically. This is because fluoroscopy allows for real-time imaging, making it particularly useful for guiding interventions and surgeries. Healthcare providers use fluoroscopy for two main purposes: for diagnostic purposes and to help guide certain treatment procedures, such as interventional radiography procedures and interoperative surgical procedures. The fluoroscopic radiologist has the unique ability to vary patient positioning as opposed to traditional CT or MR, where orthogonal views are employed without positional or temporal changes. Why use CT scans and MRI as opposed to doing fluoroscopy? The advantage of a CT scan is that the CT is digital and fully volumetric, so it can provide pictures of tissues, organs, and skeletal structure. And CT is faster than MRI. It's particularly useful for imaging blood in the brain during stroke triage. MRI offers extremely clear, detailed images of soft tissue structures that other imaging techniques cannot achieve, and it is highly adept at capturing images that help doctors determine if there are abnormal tissues within the body. As we've discussed, fluoroscopy is a type of imaging that can provide key data to find disease. It can also serve as a useful tool to guide certain treatments and surgeries. This approach differs from other types of imaging because it provides detailed X-ray of a body system or a moving part in real time. The moving pictures are cast on a screen in real time during this process, and you can use contrast or dye to sometimes highlight organs or body systems. While the procedure can produce higher levels of radiation than other methods of imaging, its benefits often outweigh its risks. The importance of fluoroscopy as a diagnostic tool has been minimized by other imaging modalities such as cross-sectional modalities, including high-resolution computed tomography, magnetic resonance, MRI, and ultrasound. The choice of imaging modality should be based upon the best diagnostic outcome for the patient and interpreting physician for proper diagnosis. Fluoroscopy provides real-time interactive X-ray projection imaging. Fluoroscopic procedures are normally performed by using an image intensifier to detect the X-ray pattern emerging from the patient after removal of scattered radiation by the anti-scatter grid. Traditional fluoroscopy has evolved and is now primarily digital. Digital fluoroscopy and analog. Analog or film screen fluoroscopy has basically been replaced by digital fluoroscopy. The reason for this is digital fluoroscopy offers several advantages over the traditional analog systems. These include superior image quality, producing distortion-free images with an improved contrast. There is also the availability of data to be stored and displayed and post-processed utilizing a digital system. Diagnostic fluoroscopy examinations have decreased in clinical practice. This has resulted in insufficient training of residents and staff and resulted in inadequate expertise or poorer expertise when compared to radiologists and radiographers of the past. Fluoroscopy remains a valuable modality even in the age of high-resolution cross-sectional imaging modalities. The benefit of diagnostic fluoroscopy is its ability to obtain a real-time evaluation with true temporal resolution, including the ability to reposition a patient during the exam. Diagnostic fluoroscopy also provides the ability for focused and functional examination of a particular region of interest. The average patient exposure during a diagnostic fluoroscopic exam can vary dependent upon the procedure, the equipment being used, and the person doing the examination. It makes a difference what modes are used during the examination and the expertise of the individual that is doing the examination. Most procedures can be done on a single exposure or a rate of 1 to 2 exposures per second while maintaining adequate image acquisition. Typically, this is between 0.02 and 0.05 grays per minute, which in the olden days was 2 and 5 rads per minute. In the early days of fluoroscopy, the X-ray photon struck the fluoroscopic screen, emitting a light direct fluoroscopy to the radiologist who was standing behind the screen and views the images. Photomultipliers, which enable visualization of weak photons to improve diagnostic radiology, were invented in 1955. Fluoroscopic procedures are used to monitor the motion of clinical objects using sequences of moving images. Supplementary technologies are used to acquire and preserve a fraction of these images for analysis later. Most fluoroscopic procedures use real-time imaging while manipulating the patient, objects within the patient, and the imaging geometry needed to optimally view those objects. This process exposes the patient to radiation risks. Fluoroscopy frequently requires the presence of operators being close to the patient, which results in their exposure to radiation as well as the patient's. The fluoroscope has transformed from a simple handheld device to a streamlined and state-of-the-art digital piece of equipment. Throughout the years, numerous changes in its design and technology have occurred, making the device more effective and safer for patients and operators. Because the images were very, very dim on the fluoroscope without intensification, the radiologists had to adapt their eyes to the room light. So they used to wear red goggles at the time prior to the procedure so their eyes could adapt to the low light levels. Here we see a 1910 fluoroscopic machine. Notice on the machine, we're taking a look at the front and the back, that there was plenty of radiation protection for the operator, and also that the X-ray tube or main beam was collimated to reduce the amount of radiation to the patient and the operator. On this particular system, it is designed so the patient must move if there is to be any motion as far as the geometry goes, and the radiologist can move the fluoroscope up and down the patient on a track. This visual shows the evolution of the fluoroscopic equipment. To the left, we see a dedicated fluoroscopic system, which allowed for the motion of the patient from a supine to an upright and in between. To the right, we see not only the ability to move the patient's table with the patient on them, but also to add the combination of an X-ray tube and a bucky to the table. In its simplest form, a fluoroscope consists of an X-ray source and a fluorescent screen, between which a patient is placed. However, since the 1950s, most fluoroscopes have included X-ray image intensifiers and cameras as well to improve the image's visibility and make it available on a remote display screen. As the technology progressed, we used an image intensifier and we looked at the images directly by using mirror optics. It enhanced the radiologist's ability to view the fluoroscopic images, no longer requiring on light adaptation and looking at a dim image on the screen itself. A spot film device was used to capture static images of the patient or areas of interest during the examination. The spot films were placed in the machine by the technologist and utilized by the radiologist to take static images. In addition to the spot film device, we were able to mount with the optics a camera or a cine camera to actually be able to record motion or videos of the fluoroscopic screen. It is important to note that modern fluoroscopes have undergone significant advancements. The mirror optics was replaced by a TV camera and a TV monitor, which allowed the radiologist to view images on the TV screen. And at some time, they went to a remote system which would protect the radiologist from getting exposed during the procedure. This didn't last long because it was not very practical. Obviously, since the beginning of ionizing radiation use in fluoroscopy and ionizing radiation use period, people were aware of the dangers of ionizing radiation exposure. Let's take a look at the progression of radiation safety over this period of time in fluoroscopy. Many scientists of the day were interested in X-ray tubes and fluorescence. One of these was Thomas Edison. He started to make fluorescent lamps, but he soon found that the X-ray had affected his assistant, Mr. Daly. In fact, Mr. Daly's hair began to fall out and then his flesh began to ulcerate. The first fatality from radiography occurred in 1904 when Clarence Daly died from complications from the experiments in fluoroscopy. Let's take a look at the life story of Sister Blandina, who lived from 1871 to 1916, and she was a radiographer that worked in Cologne, Germany. She started work in 1898. During this period of time, she controlled the degree of hardness or intensity of the beam by placing her hand behind the X-ray screen and as a filter between the X-ray beam and the patient. After 6 months, she experienced strong flushing and swelling of her hands. She was diagnosed with an X-ray cancer. She had to have some fingers amputated. Then the whole hand was amputated. Then the whole arm. In 1915, she had severe difficulties in breathing as well. And they found an extensive shadow on the left side of her thorax and a large wound on her whole front to back of her body. She died on 22nd October 1916. As you can see, we were aware of the ionizing radiation's effect on the human body, and we tried to limit the dose over a period of time. The first attempt at establishing a radiation dose limit was to eliminate doses that cause more than skin erythema, or reddening or sunburning of the hands. The next dose limit was a dose limit in 1931, which restricted your daily dose to 200 millirentgens per day. That was changed in World War II to 25,000 millirems per year. What is the radiation standard for exposure today in 2024? People working with ionizing radiation get an occupational maximum exposure dose of 50 millisieverts per year, whereas the general public gets a maximum medical exposure of 1 to 5 millisieverts per year. So let's compare that to the old standards that we had. In 1931, that would be 730 millisieverts per year. And when we reduced it in World War II, that dropped down to 250 millisieverts per year. So let's look at some practical usage of the measurement. We're exposed to radiation in several different instances, from natural radiation and background radiation all the way through ionizing radiation used in medicine. The risk from background radiation, or the exposure to background radiation, is about 8 microsieverts of background radiation a day from the sun and the earth. Now let's take a look at mechanical structures. If we were to fly in an airplane from LA to New York, we would receive more radiation dose than we would on the ground. We would receive about 40 microsieverts extra radiation dose. If we were to have a dental x-ray, that exposure would be increased to 25 to 50 microsieverts. And if we had a chest x-ray, we can see that averages about 100 microsieverts, wherein a CT scan of the abdomen, which gives us much more radiation exposure, averages out to about 10,000 microsieverts per exam. Now, when we look at this, remember, 1 million microsieverts make 1,000 millisieverts. Although the exposure level is a maximum of 50 millisieverts per year for the occupationally exposed radiation worker, the radiation worker also utilizes what's called protective personal equipment, which would be like lead goggles, thyroid shields, dosimeters, lead gloves, etc. All of these different protections reduce the amount of radiation which we receive to the different areas of the body. Whole dose radiation is the whole dose that we receive to the body. But remember, under these areas that are protected, there's a different amount of radiation that actually happens to interface with the tissue. To clarify that, or make it a little bit more obvious, let's take a look at the surgeon or radiographer working with a C-arm in surgery. Now remember, the patient gets a direct dose. The dose of radiation goes into the patient, and then it is recorded on an image receptor. The occupational dose is only the scatter radiation that is emitted from the patient. Scatter radiation, which is the most common type of exposure you will receive in diagnostic radiology, is reduced to 1/1000th the exposure the patient is receiving if you stand 1 meter away from the patient, and even less if you're wearing personal protective equipment. Fluoroscopy is utilized in a number of interoperative procedures, from orthopedics to nephrology. It is also utilized in interventional imaging in radiology. Fluoroscopy is used extensively in interventional imaging, and it is a specialty, interventional imaging, for radiologists today. Let's take a look at interventional imaging and some of the uses we have for fluoroscopy. Interventional radiology procedures can be vascular or non-vascular in nature. If they are vascular, they can either be diagnostic or therapeutic. If they are non-vascular, they can be things such as a percutaneous biopsy, abscess drainage, percutaneous nephrostomy, percutaneous biliary drainage, and RF, radiofrequency ablation of tissue. Obviously, there are a number more procedures that are utilized in the interventional suite, but this is just some of the major categories. Interventional radiology, also known as image-guided surgery or surgical radiology, is a subspecialty of radiology in which minimally invasive procedures are performed using image guidance. Some of these procedures are done purely for diagnostic purposes, such as an angiogram, while others are done for treatment purposes, such as angioplasty. Interventional radiology, also sometimes called keyhole radiology, has some advantages over surgical procedures. First of all, the procedure is minimally invasive when compared to surgical procedures, and most procedures can be performed on an outpatient basis or an overnight hospital stay, where 8 out of 10 patients go home the same day. Typically, we don't need general anesthesia to do an interventional procedure. The risks, pain, and recovery time are often significantly reduced when compared to surgery. These are the advantages of interventional radiology. Although many surgical procedures are now done as interventional radiology procedures, we still have a number of procedures that we need fluoroscopic guidance for the surgeon in surgery or interoperative radiology procedures. This is especially true when looking at trauma surgeries, orthopedic surgeries, and neurosurgeries. In intraoperative surgery, the C-arm is a crucial tool used, especially in orthopedic and trauma surgeries. However, positioning the C-arm for standard projections can be challenging due to a number of factors. One, obviously, would be the variability in the patient's body habitus. 2, it is challenging to be able to view the internal organs when we cannot see them from the outside. Trauma and orthopedic surgeries that involve fluoroscopic guidance crucially depend on the acquisition of correct anatomy-specific standard projections for monitoring and evaluating the surgical results. The downside of this is that it implies repeated acquisitions or even continuous fluorography, which can increase radiation exposure and intervention time. The movements and adjustment built into the C-arm system allow it to be oriented in almost any direction, giving a wide range of flexibility and the ability to center in different areas. However, there are limits to this flexibility and range. In addition, when using the C-arm in surgery, we find that we have single plane imaging. Fluoroscopy can only obtain images in one plane at a time, which can limit the surgeon's view during complex procedures. Next, we talk about the image quality. While fluoroscopy provides real-time imaging quality, the quality of images may not be as high as other imaging modalities. And lastly, sometimes we have to use contrast media to be able to use the fluoroscopy in surgery, and we can have a reaction to. Other challenges include the fact that interoperative fluoroscopy for orthopedic procedures frequently images are involved in the horizontal plane and require the lower portion of the C-arm or the tube portion to be rotated from an unsterile zone into the sterile field. To protect the integrity of the sterile field, the C-arm must be draped repeatedly throughout the surgical exam. Compounding this difficulty is that the experience of healthcare professionals in optimizing the use of fluoroscopy during a procedure, including the radiographer, is generally lacking, and each surgery has a random team of healthcare professionals included. Thanks for watching this thumbnail presentation of Fluoroscopy Today in 2024.